This lecture is for the undergraduate dental students. The title of this lecture is Class III Malocclusion, given by Dr.Nadia, a specialist and the lecturer of. The main topics of this lecture is to know what is the definition of the Class III Malocclusion, the classification, common classification system, the etiology, the clinical features, and then the management of the Class III Malocclusion. So according to Engel's classification, the Class III Malocclusion includes those cases in which the buccal group of the mandibular first permanent molar occlude anterior or medial to the mesiobuccal cusp of the maxillary first permanent molar. Also, in these types of malocclusion, the mandibular incisors will be overlapping the maxillary incisors, and this will reverse the normal anterior-posterior relationship of the incisors, and it is called a reverse overjet. The Class III malocclusion is the least common type of malocclusion in many communities, accounting approximately less than 5% of all the cases. The highest incidents are usually found between the Japanese and the Koreans. For the classification, it can be classified as a true or habitual based on the presence of functional shift or not in the mandible. In the true Class III, it means we have a Class III that is not associated with any forward mandibular displacement, whether it is dental or skeletal. But in the habitual, postural, or pseudo-Class III malocclusion, the maxilla are of normal size and the mandible are of normal size, and both of them have a skeletal Class I relationship, but we have certain interferences in the occlusion of the patient. So to function well and to have the maximum intercuspation, the patient has to shift his mandible anteriorly to have the maximum intercuspation between the teeth. In the majority of the cases, this happening because we have a slight retroclination of the upper anteriors of the upper incisors and a slight proclination of the lower incisors. So when the patient will occlude, there will be an interferences between the upper and the lower incisal edge, and the patient and the posterior teeth will be disoccluded. There will be a spacing between them, which is not normal for the patient and uncomfortable. So to have a maximum intercuspation, the patient will shift his mandible anteriorly and we will have an anterior crossbite. But if we compare the centric relation and the centric occlusion, there will be certainly there will be a difference between them. Also, the Class III malocclusion can be classified as dental or skeletal based on the structural component that is involved in the malocclusion. The question now is how to differentiate between the true and the pseudo-Class III malocclusion. The first thing to do to differentiate between the true and the pseudo-Class III malocclusion is to guide the mandible into the centric relation, which is the most relaxed position of the mandible when the condyle in the most superior and anterior position of the glenoid fossa. If the patient has a habitual Class III, we will see that he has got a normal overjet or an edge-to-edge incisor relationship. Also, by cephalometric analysis, the patient who has a postural Class III will have a normal SNA and a slightly increased SNB due to the forward positioning of the mandible. This is basically because he has already a normal maxilla and a normal mandible, and the reason is not skeletal, but due to the functional interferences. And the reason why I said if it was diagnosed early, because this patient, if it was not diagnosed early and not treated early, this functional shift of the mandible, this forward positioning of the mandible can stimulate the mandible to grow in such direction. And the patient will be changed from postural Class III into a true Class III relationship. In contrast, if the patient has a true Class III cases, from the beginning we can see that he has got a large SNB angle and a small SNA angle or both of them. And it really depends whether the result of the Class III malocclusion due to the underdevelopment of the maxilla or to the large mandible, long mandibular base, or both of them. Furthermore, most of the true Class III cases will have a strong hereditary components, which means that there is a genetic component of the malocclusion. We can see that his mother has also Class III, or his father, his siblings also has got a Class III, while in the postural or habitual class 3, this problem is related to the patient only, to the occlusion of the patient, so it is not hereditary. Also in the pseudo-class 3, because the patient is shifting his mandible anteriorly, sometimes we have got also a midline shift, especially if the shifting of the mandible is not only in the anterior direction but also in some lateral shift will be accompanying it. Now the etiological factor of the angles of class 3 malocclusion are those important three elements, including the skeletal, the soft tissue, and the dental. So let us start by discussing the skeletal factor. Actually, the skeletal relationship is the most important factor in the etiology of most class 3 malocclusion. And in the majority of the cases, when the patient has a class 3 incisor relationship, it is usually associated with an underlying class 3 skeletal relationship. So, the cephalometric findings of a patient with a skeletal class 3 malocclusion will be as follows. First of all, the patient will have an increased mandibular length and also a more anteriorly positioned glenoid fossa, so the condylar head will be positioned more anteriorly, and this will lead to mandibular prognatism. As we can see here from this picture, this is the normal position of a patient of the glenoid fossa in a patient with a class 1 skeletal relationship, and this is the glenoid fossa position of a patient with a skeletal class 3. Also, the patient may have a reduced maxillary length and a maxillary protrusion. But the first two factors are the most influential, which means the majority of the skeletal class 3 malocclusion are due to the mandible problems, either increased mandibular length or anteriorly placed glenoid fossa and so on. Also, the skeletal class 3 malocclusion can be associated with a range of vertical skeletal proportions, either increased or decreased. If the patient have a skeletal class 3 and it is associated with decreased facial height and a forward rotation of the mandible, this will lead to the prominence of the chin. But if the patient have a skeletal class 3 malocclusion and increased vertical height with backward rotation of the mandible, this will usually reduce the overbite and it will be more difficult to be treated. The soft tissue factor do not play a major etiological factor, but the reverse is true, which means the soft tissue will tend to tilt the upper and the lower incisors towards each other. So it will going to retrocline the lower incisors towards the upper, and the tongue will procline the upper incisors. So in other words, the incisor relationship is often less severe than the actual underlying skeletal pattern. Factor. The class 3 malocclusion are associated with a narrow maxilla and a large lower arch, and so the crowding is seen more commonly and to a greater extent in the maxilla than in the mandible. Frequently, the mandible is usually well aligned or evenly spaced because it is already large. So you will not have any dental problem in the lower arch, like a crowding, like rotation, like buccal displacement due to the lack of space. This is not common. Let us discuss the clinical features of the class 3 malocclusion, which depends on the real etiological cause or factors of the class 3 malocclusion. We have extraoral and we have intraoral. First of all, in the profile, the patient is expected to have a straight to concave profile, which depends on the degree of the mandibular prognatism and the maxillary retrognatism. Also, the patient is expected to have a long face, increased lower facial height. The mandible is usually prognatic with an obtuse gonial angle and a prominent chin. Intraorally, the patient will have a class 3 molar relationship, a class 3 canine relationship, and a reverse overjet, with the possibility that we will have a labially inclined lower incisors and a retroclination of the upper incisors. Also, the patient will have a posterior crossbite, buccal crossbite, either unilateral or bilateral, because the larger part of the lower arch is occluding with the narrower part of the upper arch. The management of the class 3 malocclusion. When treating patients with a class 3 malocclusion, there are a number of factors that can influence our treatment plan. The first of them is the patient consent, which means the patient's chief complaint and the patient opinion about his occlusion and his facial appearance is very important. Also, his motivation towards the treatment, whether he is internally motivated which means he is willing to do the treatment and he is seeing the treatment that it is something done for him, not to him, is very important. It is different from the patient who is externally motivated, which means he is pushed by somebody else to do the treatment. So it is expected to be less cooperative. Also, the age of the patient is important. The patient is growing or not. He is still have growth or not. Because if the patient has already an abnormality in the growth, we expect that the problem will be worsened by time. And also there is a possibility of relapse. Also, if the patient is growing, we may consider use some of the growth modifying appliances. All should be considered. The third factor is the nature and the severity of the problem, which is very important, and actually it is the most influential factor, because the more severe the problem, the more difficult will be the treatment plan. And we may consider using other options like the orthodontic surgery. The fourth one is the underlying etiological factors. Of course, it will be different by treatment plan by treating patient who have a skeletal class 3 malocclusion from patient who have a dental class 3 malocclusion. And this is usually after examining the diagnostic records, including the study cast and the cephalometric analysis, and also after the clinical examination of the patient. So after clinical examination of the patient and examining the diagnostic records, there are certain findings that are considered to be favorable for our orthodontic treatment, which means it tends to make our orthodontic treatment simpler and more stable. First of them is when the patient has a class 1 or a mild class 3 skeletal base relationship. Secondly, when the patient has a reduced lower facial height or average facial height. Also when he has an averaged or increased overbite, because the sufficient vertical overlap between the upper incisors and the lower incisors are considered very advantageous in stabilizing our result. Also when the patient have a proclined lower incisors and uprighted or retroclined lower incisor. This is mainly because always our orthodontic treatment aim is to increase the dentoalveolar compensation, which means that during the treatment we are going to retrocline the lower incisors, so if they were already proclined, it will be more advantageous, and the result will be more aesthetic and more stable. Also, we are going to procline the upper incisors to correct the incisor relationship, so if they were already uprighted or retroclined, it will be easier. Also, another favorable findings is when the patient have an anterior displacement on closing, which means the patient has a postural or habitual class 3. It will be much more easier to treat than if the patient have a true class 3 relationship. On the flip side, we have several unfavorable results that can make our treatment more difficult and unstable. Like if the patient have a moderate to severe class 3 skeletal base relationship, or if the patient have an increased lower facial height, or a reduced overbite, or a negative overbite, so there will be no vertical overlap between the upper and the lower incisor to stabilize the treatment. Also, if the patient have a retroclined lower incisor, so we cannot retrocline them furthermore to correct the incisor relationship. Or if the upper incisors were already proclined, so we cannot procline them anymore, because if we do so, we will end with an unaesthetic and unstable results. Also, if the patient have a true class 3, so it is not associated with any anterior displacement on closing, and he cannot establish an incisor relationship and an edge-to-edge incisor relationship, the treatment will definitely be more difficult and less stable. The main treatment objectives in class 3 occlusion will include firstly the reduction of crowding and producing the alignment of teeth. Secondly is to correct the incisor relationship to obtain the normal overjet and the normal overbite. Thirdly is the correction of the molar relationship, so the maxillary teeth will be moved forward and there will be a backward movement of the mandibular teeth to have a class 1 molar relationship. Of treatment is usually earlier than that for the class 1 or a class 2 patient, and the optimal time or the best time for the beginning of an early class 3 treatment regime in patients who have a small maxilla, and so we want to expand the maxilla and to protrude it by using the orthopedic face mask with a bonded acrylic expander, is usually coincident with the loss of the deciduous incisor, the upper deciduous incisor, and the eruption of the upper permanent central incisors and the maxillary molars, because it will aid in the retention of the appliance. And also by that time, by the age of 6 to 8 years old, still the suture of the maxilla are not fused yet, and so we can get the maximum protraction and the maximum expansion of the maxilla. Three treatment modalities. The first on which depends on the already mentioned factors. The first of all is the growth modification, the camouflage treatment, and the orthodontic surgery. For the growth modifications, if the young patient who are still in their growing phase, orthopedic or myofunctional appliances can be used to enhance or encourage the maxillary growth or restrain or redirect the mandibular growth according to the etiology of the malocclusion. The growth modification can include any one of the following appliances. As we said before, it depends on the etiology of malocclusion. The first one is by using the functional appliances, like the Frankel III appliances, which can be very useful in mild cases in the mixed dentition, where a combination of proclination of upper incisors and the retroclination of the lower incisors are required with backward and downward rotation of the mandible. So this is why we said in the findings, if the patient has a reduced vertical height, it is considered to be favorable. Because by using these appliances and rotating the mandible backward and downward, we are going to increase the vertical height of the patient. So if the patient has already a reduced vertical height, the result will be more aesthetic and more acceptable and favorable. However, the functional appliances are less widely used in the class 3 malocclusion because it is difficult for the patient to posture his mandible posteriorly to achieve an active working bite. It is more easier for the patient to protrude his mandible than to protrude it backward to obtain the working bite. In this video, we are going to see that this patient has a class 3 malocclusion due to protruded maxilla and protruded mandible. So he's going to be treated by using the Frankel III myofunctional appliance. The lip pads are located in the upper arch, so it's going to stimulate the forward growth of the maxilla, and we'll get also proclination of the upper teeth and a slight retroclination of the lower teeth. These cheek pads will also stimulate the expansion of the maxilla to correct the posterior crossbite. So this is before and this is after treatment. Now the other treatment modality in growing patient is by using the chin cup, especially in class 3 malocclusion due to mandibular prognatism. It has the effect of rotating the mandible downward and backward with the reduction of the overbite and the increasing in the lower anterior facial height. The pressure from the cup will tend to tip the mandibular incisors lingually, and the patient is usually instructed to wear the appliance about 14 hours per day. The optimum time for wearing the chin cup appliance is before the maximum growth spurt of the patient, which is in females about 10 to 12 years old and in males about 12 to 14 years old of age. Now, if the cause of the skeletal class 3 was due to a deficiency of the maxilla, the patient will be instructed to wear the protraction face mask, with or without an expander, to expand the maxilla posteriorly, especially if it was associated with posterior crossbite. The protraction face mask usually exert about 400 grams per side, and usually the patient should wear it about 14 hours per day, so we need a cooperative patient. And as we have discussed before, it should be used after the shedding of the deciduous incisors and the eruption of the permanent incisors before the maxillary sutures fuse together if we want a skeletal effect. Another treatment modality is what is called the orthodontic camouflage. In the orthodontic camouflage, we tend to increase the dentoalveolar compensation. So especially if we have an adult patient with a mild to moderate class 3 skeletal relationship, we may consider using fixed mechanotherapy. And the camouflage is usually achieved by proclination of the upper incisors and retroclination of the lower incisors, or sometimes both of them. If we need a space to correct the crowding in the upper arch, we may consider expanding the maxilla anteriorly and posteriorly if it was combining with a buccal crossbite. And if we need a space in the lower arch for the retroclination of the lower incisor, we may consider extracting the lower fourth. Unless the arch is already spaced, so we may get use of the already existing spaces. Last treatment modality is the orthodontic surgery, which should be considered for those patients where the orthodontic treatment alone will be challenging due to the severity of the skeletal disproportions, like in cases of severe mandibular prognathism or severe mandibular retrognatism, or if the anterior-posterior jaw discrepancy were associated with vertical discrepancies as well, such as increased facial height or anterior open bite, we may consider the surgical repositioning of the jaws to have a more stable results. But the surgical procedure usually should be postponed until adulthood, when all the growth has ceased. In this slide, we will see the summary of treatment in Class III malocclusion patients. For the non-growing patient, we may advise the patient to accept his malocclusion, especially in those cases where the overbite is minimal. It may be preferable to accept the incisor relationship and direct treatment towards achieving arch alignment only. Also, for some patients where more severe Class III incisor relationship are there, they are unwilling to undergo comprehensive treatment involving the orthodontic surgery, which may be required to correct their incisor relationships. The second option will be the orthodontic camouflage treatment, and the last one will be the orthodontic surgery. And if the patient is growing, we may also advise him to accept his mild malocclusion, as we said before, if it was very mild and it doesn't affect his functional or his aesthetic appearance. And the second option will be the growth modifying appliances, and lastly the orthodontic camouflage treatment. This is the end of the lecture. If you have any question, please do not hesitate to contact me through my YouTube channel or through the Google Classroom. Thank you.